Just quickly want to do another introduction for anyone who joined late. My name is Alex Mitchell. I'm a communications manager with the Lighthouse Lab Services team. And thanks for joining us for tonight's talk on emerging street drugs and new threats to watch for. Our presenter tonight will be Dr. Erik Korte, who I'll introduce here in a minute. But I want to quickly turn things over to Robin Hoyle. She's the executive director of the pain societies that we're partnering with for this webinar series, and just want to let her say a few words up front. So, Robin.
Thank you so much, Alex. Thank you, Dr. Korte. Thank you for tonight. We, as you know, many of your attendees this evening are members or they have come to our meetings in New York, Tennessee, Pennsylvania, North and South Carolina. We have a very big audience, and we're very excited to partner with you, all of you at Lighthouse Lab Services to give these great talks. Great one last week on Urine Drug Testing 101. Tonight, very excited about this emerging street drugs topic. And then I just want to remind everybody on the call on Wednesday, November 15, we will have our next one, developing a custom test menu for urine drug testing. And then our final one will be Wednesday, December 13, and it will be coding and billing for toxicology best practices. I just want to remind everybody, because I've been getting a number of emails at the office over the past couple days, that you claim CME at the end of the series. I promise to send you out a note. Alex and I both will send you notes that say, here's how you claim your CME. You do have to participate in the live simulcast to earn CME, but we are recording and we will make these available to you so that you can go back and watch them again. Bring them to the, load them at the office during a lunch hour and share them with your team. Anyway, Alex, thanks for the few minutes. Thank you so much for your generous grant and for your talent and your expertise on these subjects. And we're excited to get started.
Thanks a lot, Robin. I appreciate that. Just quickly, I want to go into a little bit of background on Dr. Korte. He is a lab director and a clinical consultant for Lighthouse Lab Services. He attained his PhD in biochemistry and molecular biology from the University of Louisville, where he also completed a fellowship in clinical chemistry through the university's Department of Pathology and Laboratory Medicine. Prior to joining Lighthouse, Dr. Korte served as Vice President of Laboratory Operations for Blue Water Diagnostics of Mount Washington, Kentucky. And prior to joining the clinical side, he also spent years doing opioid research. So we're really glad to have him on today, sharing his expertise. And with that, I'll turn it over to him.
Thank you, Alex, and thank you, Robin. All right, first disclosures. I am a paid employee of Lighthouse Laboratory Services. I serve as both a laboratory director and clinical consultant for several toxicology laboratories and general reference laboratories. All efforts have been made to remove any commercial or financial bias from this presentation. References are provided with accompanying data, and unpublished data is shown in a limited capacity at the end and is clearly marked as unpublished. So brief introduction for the talk. We've already introduced the talk series. We're talking about the objectives. I'm going to use emerging street drugs as an example for how to approach adding a new drug to your test menu. We'll talk about fentanyl. We'll talk about xylazine. I'll conclude, and then we'll have a brief Q&A at the end. Now, this talk is a little different than talks that I've given in the past. My goal is not to send you home with 15 drug names to listen for at your next conference. I want to illustrate how novel drugs can evolve and move through your patient population. I would like you to take from this talk not a list of drugs that you want to test for, but rather a list of ideas on how to identify and justify the 1 or 2 drugs with the highest impact on your patient population that afford you the greatest chance of successful intervention if added to your test menu. So this is no longer the good old days with a few opiates, cocaine, and PCP with a library of scientific literature and clinical trials outlining each drug type. Today's drugs are a moving target. Some have staying power, but many are only prevalent for 1 to 2 years nationally and may only reside in the local ecosystem for weeks or even days at a time as a shipment batch is produced and distributed and then consumed. Designer drugs are dangerous and they're unpredictable because they're frequently more potent, they're longer lasting, they have a higher addictive potential, and many have never been tested on humans, or they failed human trials in the 1950s, and there's no regulatory oversight since then. So how do you need to respond? So this talk is aimed predominantly at physicians and laboratory directors caring for a specific patient population. It's not directed at forensic toxicologists or ER docs who are going to see a wide variety of novel drugs and have a need to identify them in the moment. We cannot test for everything. What we want to do is do the most good we can with the resources that we have available. So the objectives of the talk have this goal in mind. So first, we're going to briefly discuss immunoassay and mass spectrometry, not necessarily to understand the science, but to highlight the differences between the two methods and how you can harness those differences to help you potentially identify the presence of a novel drug as it enters your patient population. Next, we'll have a pragmatic review of emerging street drugs. Again, the goal is not to fill your head with names, but to use these street drugs as examples of what to expect as novel drugs move through your area. Specifically, we'll discuss the opioid crisis and how you can respond. And finally, I'm going to use some of my own data to show you how I'm approaching specifically Xylazine in my patient population that my laboratory serves. I'm not going to claim that Xylazine is a requirement for your patient population, far from it. There are absolutely regional differences in the prevalence, and my data may not be applicable to your patient population. But the reasoning behind adding Xylazine as a target in my patient population is important, and that is going to be the focus. So first, when it comes to emerging street drugs, if we want to add a drug to our target menu, we have to understand the testing options and the requirements for adding a new target. So we'll briefly discuss the differences between screening or presumptive testing and confirmatory or definitive testing. In addition, any new assay requires acquiring quality control materials and enrollment and proficiency testing, which can be a major stumbling block even for a new assay, especially for novel designer drugs. So in addition, the cyclical nature of modern designer drugs means that the drugs may not be present in the ecosystem for long after the validation is completed, let alone be present for long enough for the validation to be useful. So briefly, let's discuss screening methods. So screening or presumptive testing usually involves an immunoassay. This example is just a very simplified cartoon explaining the different parts of an immunoassay. So it uses antibodies, which are specific to a drug target and tend to be bound to a surface. In this case, solid phase antibodies, they're bound to, say, the bottom of a cup, a reaction cup. A urine sample containing drug or metabolites is then added to the cup. If the antibodies come in contact with a drug or metabolite that they have a high affinity to, then they'll bind onto it and they'll hold onto it. Next, a second antibody is added that is labeled with a target or labeled with a compound that can produce light or undergo chemical reactions, something that could be measured. The second antibody is also specific for the drug or metabolite that we're looking at. And when it binds, we see an increase in signal, whatever the signal may be, with increasing signal corresponding to an increase in the amount of drug in the sample. Now, there are lots of different variations of this, but this is a good enough example to keep in your mind for the rest of the talk. So antibodies are great, and they have some level of sensitivity and specificity, but they're not perfect. An antibody may bind to a specific target with very high affinity, but there are usually going to be other targets that it'll still bind just with less affinity. So this is how screens frequently result in off-target effects and false positives. But because of this, immunoassays are great at detecting entire classes of drugs. So the entire class of amphetamines, for example. But they tend to have problems when we're looking at a specific drug or that drug's metabolite, and we need to differentiate it from another similar compound. So that's a job for confirmatory testing. So confirmation or definitive testing is typically going to be LCMS, or liquid chromatography tandem mass spectrometry. LCMS is both highly sensitive and highly specific, which is both a blessing and a curse. It is going to separate compounds in two different ways. First, it's going to separate by time based on their interaction with a column, and then by mass and structure based on their mass to charge ratio. So to separate by time, we inject the sample into a column. Everything in the column is added in together. Some things are going to stick to the column more than others. If something interacts with the column, if it sticks to the column, it's going to take longer to pass through the column. If something doesn't interact with the column very much, it's going to pass through faster. And so over time, over 4 or 6 minute run, you're going to see some things pass out quickly. So they're going to be through the column in a minute. Other things are going to take a little bit longer. They're going to take a full 6 minutes to come out. So we're separating these based on time. As things pass through the column, everything that elutes from it is going to be added into the mass spec. So the first step is that the compounds are essentially put through a taser to put an electric charge on the compounds before feeding them into magnetic fields that are generated by the instrument. So all of the compounds have a mass to start, and now we've just applied a charge. These magnetic fields are set to a specific mass to charge ratio for a compound that we want to measure. So down here at the bottom, you can see Q1. This is the first quadrupole. It isolates the compound with the desired mass to charge ratio that we know the parent drug has. The second is a collision chamber. The collision chamber is full of an inert gas, argon, nitrogen, something so when the compound hits it, it can break apart and it fractures in a known formation, a repeatable structure or component of daughter compounds. Now, these daughter compounds still retain their mass and they still retain their charge. So now we have a second mass to charge ratio. So Q3, the third chamber of the triple quadrupole, is going to now select for the daughter mass to charge ratio. Everything that doesn't fit that specific ratio is going to be ejected, and only the daughter compound that we're looking for is going to reach the detector. Causes a little peak, and then we know exactly what we have. So these methods are incredibly sensitive. They can easily measure down to the picogram levels, and because there are 3 different steps of selectivity between the column separating by time, the parent mass to charge ratio, and then the daughter mass to charge ratio, the specificity is also incredibly high. So it's a very sensitive assay that will detect a very small amount of drug while being very specific in the complex mixture. So how do we use them? Immunoassays are fast, easy, and inexpensive for the most part. They do have lower sensitivity and specificity. They have frequent false positives and false negatives, but because they are not quite as specific as LCMS, they may detect novel drugs. A lot of novel drugs only vary by a methyl group or hydrogen at a different location. These are things that if an antibody can detect, but the mass spec is going to be specific enough, it is going to exclude anything with even an extra hydrogen in most cases. So the confirmatory testing, it's more expensive initially. They're very challenging validations, but they have extremely high sensitivity and specificity. You're able to put different parent compounds and metabolites together, and it can differentiate them both in a quantitative way. But this specificity means that novel drugs usually are going to be excluded. If you put an extra methyl group in there, you're not going to be able to detect it in mass spec. So how do you use this knowledge since you're doing both screens and confirmations? So 2 interesting ways to use it. First off, with a specific patient, if you have one patient who always seems to have a positive screen and a negative confirmation, it could be that they just have a different metabolism. They have genetic polymorphism that shunts this drug into a different pathway, or they're on an inhibitor, so they have polypharmacy, and they're on a CYP2D6 inhibitor that's going to, instead of producing a lot of hydromorphone, they're producing norhydrocodone. They're going in different directions. So that can be useful when you have a patient where their screen and their confirmation don't consistently agree with each other. But more on the topic of the talk is increasing positivity in the immunoassay that's not replicated in the LCMS. So think about like a benzodiazepine assay. So your benzodiazepine screen suddenly across multiple patients over multiple weeks start popping positive. But you don't see it in your confirmation. None of your benzodiazepine confirmations are testing positive. This is a very likely sign that you have something new in the environment. You have a new benzodiazepine that is not part of your test menu. This is a good time to get on the phone with local hospitals, poison control. Police can be a good resource, forensic toxicology labs. To figure out what this new drug is, figure out if it's something that has staying power that might be around that you may want to add to your test menu. So now let's get into the meat of the talk with our first emerging street drug. All right, synthetic cathinones or bath salts are named for their visual similarity to Epsom salt. They're human-made products that are similar to cathinone. Cathinone's a naturally occurring stimulant found in the leaves of the khat plant. It's been traditionally chewed for centuries in East Africa and the Arabian Peninsula for its euphoric and energizing effects. It's chewed mostly as a social function, but also has some mild stimulant effects. It's not as innocuous as drinking coffee for caffeine, but arguably it is better for you than tobacco or alcohol consumption. Structurally, it's very similar to amphetamine. Cathinone is one carbonyl group away from amphetamine, as you can see from the examples here. They're essentially ketone versions of amphetamines. In the bottom left, you can see methylone is MDMA without the ketone group. They are otherwise the same compound. So bath salts have gained notoriety for their potent and often unpredictable psychoactive properties. These drugs have a clear boom and bust cycle. So let's take a look at the timeline over the last 10 to 15 years in the synthetic cathinones. So most timelines for the bath salts start in the 2000s as a club drug in the UK. The first time it makes a noteworthy appearance in the US was 2009. By 2010, there were 300 calls to poison control. By 2011, we saw 6,000 calls to poison control. And by 2012, the wave began to recede a little bit, and we only saw 2,600. This is the classic boom and bust cycle of street drugs. So as forensics and clinical laboratories became better and more aware of the different isoforms and testing expanded, we started being able to detect more specific targets predominate over time. So in 2012, methylone began to dominate. It dominated between 2012 and 2014. Ethylone, with one extra carbon added, was present for 2 years, but it never really took off. Really only spent about a year in the spotlight before N-ethylpentylone took off. So N-ethylpentylone really hit in 2016. N-ethylpentylone, it was ubiquitous until 2019 when Eutalone began to dominate. Eutalone was arguably had the best run out of the four. It only began to lose dominance during the pandemic. Now, something to notice, each of these targets only lasted 1 to 3 years, and even that was very regionally dependent. So now, according to Fogarty and authors, the article that I have listed at the top, based on prior trends of other new synthetic cathinones, it's expected that N,N-dimethylpentylone may predominate the U.S. synthetic market over the next 1 to 2 years, and there's some good evidence to support that. And it may have actually started a little bit earlier because as Eutalone began to fall away, we started seeing increasing reports of pentylone in the population, which is a major metabolite of N,N-dimethylpentylone. So the authors made the case that N,N-dimethylpentylone is probably going to be the next big synthetic cathinone for 2023 and 2024. Now, the goal of the talk is not necessarily to have you go home remembering the structure of N,N-dimethylpentylone. I'd like you to remember the boom and bust cycle of the synthetic cathinones over the last decade. You can spend all of your efforts chasing targets with very little to show for it if you pick the wrong drug. So let's have a slightly different example. So benzodiazepines are a class of CNS depressants originally introduced in the 1960s as a safer alternative to barbiturates. Large doses of benzodiazepines are rarely fatal unless combined with other CNS depressants like alcohol or opioids. So they did do a good job of replacing barbiturates in that realm. They're frequently prescribed for anxiety, insomnia, seizure disorders, among other conditions. And while the therapeutic benefits are very well established, we're all aware of the concerns about dependency, withdrawal, and potential misuse. So individuals abusing benzodiazepines can obtain them multiple ways. They can get multiple prescriptions from several doctors. They can forge prescriptions, or they can buy drugs that have been diverted from the licit market onto the illicit market. This is made up of both foreign and domestic illicit products. Alprazolam is one of the top 3 prescriptions diverted from the licit market into the illicit market. In 2021, there were almost 17,000 reports to federal, state, and local forensic laboratories about alprazolam alone. Within the novel designer benzodiazepines, the numbers are lower, but still easily into the thousands. So benzodiazepines are usually used in combination with other drugs. In fact, they can mitigate the effects of cocaine or stimulant binges. They can kind of take the edge off as you're coming down. The problem with them is that there are a lot of them, but that's not why I'm using them as an example on this list. So why are benzodiazepines such a problem? The first is that they do have a very high potency. The designer benzodiazepines in particular. While they may not be the most toxic drugs on the market, the level of impairment they provide is one of the main factors why they are seen in so many postmortem cases, as well as DUID or driving under the influence of drugs cases. Second, they have a very rapid onset, short half-life, and rapid excretion, at least related to other designer drugs. The rapid onset makes them common weapons for sexual assault, which is something to keep in mind because when running a pain clinic or an addiction center, this means that your patient population is statistically at greater risk of sexual assault. And there's always the possibility that a patient could test positive with no memory of or intent to take benzodiazepines. So, but it's the second two factors that I want to focus on for this talk. Those short half-life, rapid excretion drugs. Benzodiazepines are metabolized fast enough by the cytochrome P450 system to the extent that some assays don't even test for the parent compound. We test directly for metabolites. So think about 7-aminoclonazepam. So in addition, the rapid excretion means that you may not see these drugs for very long after a dose. So if you see a patient every 2 weeks, they can easily titrate out their illicit doses so that you may never notice them. And due to the high potency of many of these novel forms, doses don't need to be very high. So now we have low concentrations with short time windows of detection of benzodiazepines. This requires use of a very highly sensitive method to detect these type of drugs. So the benzodiazepines are moving targets. You'll see them in the clinic, but knowing when it's time to add a new target is a challenge. So I have a couple references at the bottom that I highly recommend that you look at. First, the first link, the DEA releases drug and chemical evaluation section on pretty much everything. They're usually just a single page, and they provide a concise review of the current understanding, metabolism, street names that your patients may use, as well as other important data. They make great provider education handouts when you bring in a new assay. So if you run a laboratory and you bring in a new test method, you want to educate your providers on the test method. These are great resources for that. But you can literally download them from the site and send them out, and they're great. Underneath that is the United Nations Office on Drug and Crime on current NPS threats. This is also extremely short. It's 5 pages long, and it is an excellent read. It comes out every year, and the current one was just released in August. And the link below will take you directly there. So it includes trends from all over the world, although the majority of the data is submitted from the US and Europe. So the data definitely tends to skew more towards domestic patient populations, which makes it very useful for us. It's broken down into extremely digestible sound bites. It's something that you could circulate among your coworkers when it comes out each year. So the UNODC also maintains the Tox portal, which you can find at the same site, which is a great resource for exploring specific trends in your patient populations or demographics. It breaks things down regionally into, it's just a good way to approach what could be coming or what may be in the area. If you do have a time, like where your benzodiazepine screen for several weeks doesn't match the confirmation results, it's a good time to get into the Tox portal and see if something's being detected in the area. Now, if you've not downloaded the handouts for the talk, please do. These should be clickable links, and they can take you directly to the documents. And I can't stress enough, these are great documents, so definitely grab them. Okay, moving on to the opioid crisis. Now, we don't really need that much of an introduction to fentanyl. I do want to offer up a resource. The report at the top is from the RAND Corporation. It's a very comprehensive story about the emergence of fentanyl and other synthetic opioids. It is a couple of years old, and it's much longer than the last two suggestions. So it's more of a reference material than a cover-to-cover read, but still very good. Some of the interesting quotes are, the emergence of fentanyl was more based on supplier decisions and not user demands. that makes a lot of sense on the financial side. So fentanyl is cheaper than the alternatives. It also makes sense logistically because it's more concentrated. So it's easier to carry fentanyl. It's easier to hide fentanyl than some of the other opiates. People weren't generally asking for fentanyl. This wasn't something that the users were asking for. It was dealers that were supplying it that were making the decision. Another interesting quote was that the adoption of synthetic opioids drive up deaths rather than the number of users. It is a fairly morbid statement, but it's an important thing to understand because it allowed us to transform from a goal of trying to prevent people from becoming addicts to increasing the ability of addicts to survive long enough to emerge from their disease. This understanding is one of the reasons that we have easier access to Narcan than we did just a number of years ago. So, talking about fentanyl, in your lab, should you be aware of parafluorofentanyl and carfentanil? Are they appropriate additions to your test menu, or aren't they? Nothing is going to compare to fentanyl in raw numbers, but there are other targets that we can look at. So, furthermore, since fentanyl is so ubiquitous that a test for fentanyl will genuinely identify other opiates and many other illicit compounds at the same time, whereas it will show that your patient is on fentanyl, illicit fentanyl. What is the benefit to knowing specifically other illicit compounds that they're on when you already know that they're on an illicit drug? Is that good enough for your patient population? Is it good enough for you to be able to intervene in your patient's care, knowing that? So if you're trying to identify a patient who's relapsed and begun using illicitly, this is the closest thing that I'm going to get to making a blanket statement that your lab should be testing a target. But you should be testing for fentanyl if you're not already. And we'll come back to that concept here in just a minute. So a brief recap of the 3 waves of opioids that have moved through the US in the last 15 years. Well, 25 years. In the late 90s and the early 2000s, we saw a rise in prescription opioid-related deaths. These increased until about 2010 and have mostly stayed consistent since then. In 2010, the second wave hit and was initiated by an increase in heroin overdose deaths. A couple of years later, synthetic opioids began to emerge, but by the middle of the decade, synthetics had overtaken both prescription opioid and heroin in total mortality. And since then, they have continued to rise with only a slight dip during the pandemic as supply chains were disrupted. But again, this is not the focus of the talk. The question is, how should the laboratory respond? How should you respond to the patient that is sitting in front of you? Obviously, once again, you do need to test for fentanyl. Fentanyl would be present because it just makes sense to dealers and chemists. It's easy to put in, it's cheap for them, it's easy to transport, it's easy to smuggle. It's more concentrated, so they only have to traffic a small amount to get this to supply their population of users. But the question is, do you need to test for all the fentanyl analogs? So down here at the bottom, well, this is a great little paper from Morbidity and Mortality World Report. It came out last year, but it highlights the rise of parafluorofentanyl in several regions around the country. Parafluorofentanyl is just fentanyl with this highly reactive fluoral group in the 3rd position. Now, looking at their data, you can see fentanyl is the solid line at the top, and you can see the bar graph increase as the number of deaths involved with IMF, which is predominantly parafluorofentanyl, increases. So parafluorofentanyl, something to note here is that the vast majority of cases, even as the parafluorofentanyl increases, the vast majority are still going to have fentanyl on board. So in the vast majority of cases, as long as you identify fentanyl, you've identified an illicit compound and you know that you need to intervene in this patient's care because they are using illicit drugs. Is it worth trying to dig into all the different compounds? Is that going to provide better care, or is it going to take time and resources away from something else that you could be looking at? Let's take a look at another example with multiple analogs. So the fake opioids, the nitazines. At first synthesized in the 1950s, they can be more or less potent than fentanyl, depending. We don't always have great data on the potency, unfortunately, with a lot of these drugs that come out. But starting out with isotoniazine, it hit the middle of the country, Kentucky, Ohio, Indiana, and Illinois, right where I'm located. It's in 2019. It is still around, but not anywhere close to the levels that it was seen at originally. Metonidazine, less than a year later, it replaced isoniazine with the new pair of methyl groups and a slightly higher mass to charge ratio. So it is a brand new compound for anyone who developed an assay targeting isotoniazine in August of 2019. Then half a year after that, we have our third form, what is essentially the exact same drug, but this time with a longer side chain. So we have a different mass to charge ratio with different retention times. So there were labs that spent weeks or months validating each of these compounds only to have them disappear shortly after the validation was completed. But in each outbreak, something to note, in each outbreak, the majority of cases had fentanyl on board. So identifying fentanyl in these cases is frequently enough to intervene and help guide the patient's recovery, bring them back on track. Now, if your patient has high rates of fentanyl prescriptions, this may not be the case. You may want to add specific analogs. But in my particular patient population, fentanyl prescriptions are extremely rare, and any fentanyl I detect is invariably going to be illicit. So, how should the lab respond to the opioid epidemic? I would answer deliberately and with purpose. You have to make decisions that are based on your patient population and your testing needs. So let's transition to another emerging street drug, Xylazine. I'm going to show you why it's a little bit different in my population than other street drugs. So Xylazine was first synthesized in the 1960s by Bayer as a non-opiate sedative, analgesic, and muscle relaxant, but it failed human trials due to unacceptable hypotension, bradycardia, sedation. It did find significant use in the veterinary world, but human data for the last 5 decades is very limited. I have a very nice article describing serum xylazine concentration in ostriches required for analgesia and euthanasia, but nowhere near that level of detail regarding human physiology. So while xylazine has emerged into the public discourse only recently, it's been present in the background for much longer than that, probably at least since 2000. We didn't know that it was at the time that it was the problem that it is, so we just haven't been looking for it. Now that we have some data, below are just 2 figures showing an overlap of fentanyl and xylazine overdose deaths. Now, at first glance, they do look similar to the data that I just showed you for emerging street drugs, where fentanyl and the street drug overlap fairly well. Therefore, testing and identifying fentanyl in a clinical setting is usually sufficient to intervene in the patient's recovery. But xylazine can be a little bit different. So as I said, the pharmacokinetic data is limited in humans, but lethal doses have been reported in the 40 to 2,400 milligram range. Non-fatal plasma concentrations range from 0.03 to 4.6 milligrams per liter, and fatal cases range anywhere between trace and 16 milligrams per liter. So knowing these fatal and non-fatal dosages, consider that xylazine can be as cheap as $6 per kilogram in powder form, and can be purchased from legal veterinary suppliers in the US. So although illicit supplies tend to be an easier source, this 50 ml bottle listed at a pet supply company at a concentration of 100 milligrams per mil is sufficient to kill between 2 and 125 people. A kilogram of powdered xylazine that could cost as little as $6 is sufficient to kill 400 to 50,000 people. The point is that it is similar to fentanyl in that the dealers have a strong economic incentive to use it. But the difference between fentanyl and xylazine is that there's also pressure from the users because xylazine reportedly gives fentanyl wings. It improves and extends the high. So the users are asking for it as well. Sadly, deaths are typically deemed unintentional rather than being suicides or homicides, but this, in the light side, this does make these cases where intervention may help. Very importantly, xylazine is not an opiate, so Narcan is not effective. Narcan should always be given in cases of suspected overdose, but it will only treat the opioid component of the overdose. It will not relieve any of the sedation from the xylazine itself. So in my clinic, we anecdotally see good detection with a cutoff of around 10 nanograms per mil. And we see an average concentration in urine of a little over 1,000 nanograms per mil in positive cases. Again, this is unpublished data. So let's take a little bit closer look at my data. All right, again, this is unpublished. It's not been peer reviewed yet. I pulled every single sample that went through our laboratory since the beginning of July until last weekend, so about 4 months worth. About half of the patients, half of the samples that came through were positive for at least one illicit drug. Methamphetamine and fentanyl obviously dominated by far in 30% and 28% of cases overall. Xylazine was in a third with 15% of cases, well over 900. And this is well ahead of cocaine and heroin at 9% and 3% respectively. But again, our goal in the clinic is not necessarily to identify every compound in the sample. It's to identify enough that we can intervene in the patients that need it. So I've shown you multiple examples that street drugs are present with fentanyl. So identifying fentanyl is sufficient to know that a patient is using and allow you to intervene in their therapy. So that's where I was the most interested in the drug combinations listed in the second table. Methamphetamine alone accounted for the vast majority of isolated cases, with 902 cases out of just over 6,000 that were positive for no illicits other than methamphetamine. Fentanyl was next with almost 500 cases, and then methamphetamine combined with 388. But what really piqued my interest was in fourth place, xylazine alone accounted for 281 cases. This means that almost 5% of all cases that came through my laboratory since July 1st were positive for xylazine as the only illicit drug. And then as you move down the list, you see combinations of xylazine and methamphetamine, xylazine and cocaine, xylazine, meth and cocaine, and so on. So cocaine is absolutely present, but in this population, it's present alone in just a fraction of cases compared to that of xylazine. And then heroin is even lower. So in this case, cocaine and heroin were much, much easier to identify in combination with other drugs. Xylazine was a big surprise. The fact that it is alone in 1 out of every 20 patients that comes out of my laboratory. So almost 300 cases since the middle of the summer have been positive for xylazine alone as the only illicit drug. Now, here's the problem with that. I'm looking at the raw data that came off the LCMS. This is not what gets reported to providers. Providers see only what they ordered, and my providers are just not ordering xylazine. Of 938 positive xylazine cases that came in since July, only 2 were actually reported back to providers because only in 2 cases was xylazine actually ordered. This means that over the last 4 months, 1 out of every 20 specimens that has been sent to the lab was positive for an illicit that we have not been able to report to the provider. Now, I didn't know what our levels of xylazine, I didn't realize that our levels of xylazine were quite this high until I pulled the raw data for this talk. After seeing this, I now have a meeting scheduled next week with providers to show them this data with the goal to change their ordering practices. We can confirm for cocaine and we can confirm for 6-MAM for heroin, but these data suggest that it would have a much greater patient impact to drop one of those targets and instead confirm xylazine on a standard panel. So xylazine should be added to our definitive 7 or definitive 14 so that providers have it on a regular basis. They know if the patient is using illicit drugs in this case. Now, I have to be very clear, this data came from my specific population that my laboratory serves. It has been very clear and consistent in this population over 4 months, but I was curious. So I looked at what I thought would be a similar population from Pennsylvania, and I did not see the same picture of xylazine in that population. It was absolutely present, but the numbers were slightly lower, and it did tend to be present more often with fentanyl, in conjunction with fentanyl. So based on my data in my lab, I should very clearly be testing xylazine in the lab that produced this data. This does not mean it is something that you should be doing in your patient population, because they are very likely different. There are going to be regional differences. There are going to be differences within regions on patient usage and patient exposure. So I'm at a huge advantage with this situation because I already have validated xylazine. It's been validated for months now. I have data showing that it is worth testing. It just needs to be ordered. It would be a much more difficult question to answer, should I test xylazine, if I didn't already have this data to share. So this is why when it comes time to make decisions for your laboratory on what needs to be tested on your patients, you need to do so deliberately based on all the data that you can acquire for your patient population. You can't make this decision based on one database or one article, one conference speaker, or even one Wednesday night presentation, no matter how well-meaning it might be. Chasing after the wrong drug will consume time, money, and effort. It'll consume your resources, and it may have little or no benefit if you pick the wrong drug. So take your time, respond deliberately. So in conclusion, I've tried to script my conclusions with some precision so that you can come back to the handouts later if you want and get all the information that you need from the slide. So I'm actually going to read these mostly verbatim just so that I can stay on topic. So conclusion 1, for any new methods, you have to balance the effort of the validation with obtaining control materials, securing proficiency testing, with the benefit that that analyte will provide your patient population. You have to make an educated guess for how long that analyte is going to be around. Is it actually worth testing? Emerging street drugs can be incredibly important topics for the clinical laboratory to identify, but goals have to be specific, and designer drugs are particularly transient. They're going to come in and out of the population, even within regions. The lab should remain responsive to new drugs by knowing and constantly reanalyzing the patient population to predict what new targets are worth adding to the test menu and which will only divert resources from more important tasks. So the one soapbox that I told you I will get on is that inclusion of fentanyl, metabolites, and occasionally some of the related compounds is more than likely going to be beneficial in most regions of the country. If you're not testing fentanyl already, you should. But my specific example, xylazine may be an important target to add to a test menu, potentially at the expense of other less common targets. Now, be aware that your test population may be aware of your test populations and make decisions accordingly. And also make sure that your providers are aware of these findings so that they can order appropriately. All right. When it comes time to make decisions, just take your time and get advice. There are lots of resources, the CDC, the FDA, the DEA, the UN. But don't discount your state departments of health, your local community, hospitals, emergency rooms. If you have contacts in emergency rooms, ask them what they're seeing. Police, poison control, and I'm sure most people know, but patients themselves. Patients, you're always going to run into that one patient who wants to open up about everything. They're going to tell you every single thing they've heard. That's an important resource. So talk to them, use them, try and figure out what they're hearing about coming through the area. Educate yourself. So there's so many different ways to educate yourself. Your current suppliers for PT, controls, split sample testing, other laboratories, instrument manufacturers. If you have a specific screening assay, or if you have a specific mass spec, call the manufacturers, see if they have any advice. And then make use of your own data. You can take the raw data off the instrument. You can data mine it. You can see what is in the area outside of what necessarily has been ordered. So do what you can. You have a lot of resources at your disposal, but when it comes time to actually make a decision, make it slowly, make it deliberately, and hopefully make the right decision. So I believe that's everything for the moment. We still have about 5 minutes. We can open up the floor for some questions.
Yeah, thank you again, Dr. Korte. We appreciate it. That was a great presentation there. I have some questions here in the Q&A section. If you move over to published, you can see what folks have been asking. I think really quickly before we dive in, can we get some additional context on the unpublished data you shared? Richard in particular was wondering about the type of clinic you're working in. Are these results in a pure pain clinic versus physicians who treat in orthopedic or primary care offices? If you could expand on that a little bit.
That's a very good question. And again, thank you for noticing, because the specificity of the population is going to be very important in choosing what needs to be added to your test menu and what doesn't. The clinic I'm looking at, it serves two different groups. One is an opioid dependency center, and then the other one is a standard pain center. So it tends to have a little bit more of the abuse potential than an orthopedic clinic or a general pain clinic would.
And then just to follow up on that, Richard, also, 3,000 cases in 4 months sounded like a large number to him. Could you give context for maybe how many roughly samples that was out of? And you said 2 clinics, correct?
Oh no, it was I believe we're a total of 9 clinics.
Oh, 9.
Total of 6,000 samples in 4 months. Definitely not the largest toxicology laboratory, but it's nice because it serves a very specific population. It's a lot of high repeats in this population, so you can kind of narrow down a little bit what the population needs. Obviously, if you're working in like an NMS lab or a Mayo, you're going to see different things. If you're working at a high forensics laboratory, you're going to see more weird cases. But for us, seeing something like that come out of what I see as a fairly normal patient population was a big surprise. That's a lot of illicit use that I would not have expected, and especially to have it go, essentially unreported to the clinician, to the providing physicians, just because it wasn't known, it wasn't ordered.
Well, thanks again for expanding on that a little bit. Steve asked pretty early on here about Delta 8 and Delta 9 THC. Can those be differentiated by LCMS? Delta 8's legal, for example, in Tennessee, and he has some patients who test positive for THC during the screen.
Yeah, you can confirm Delta 8 versus Delta 9. We have a similar issue with people wanting to confirm ETG versus ETS, ethanol. If we have a screen, and do you really need to confirm it? Based on when the last use was. Same with methamphetamine. You have your methamphetamine isomers, D versus L. You absolutely can. The question is, it could be worth it in your population if you want to test, somewhat licit versus illicit THC. So yes, it can be done. It absolutely can be done. Whether it should be done on a major panel or it has to be a completely separate panel, like with ethanol and frequently methamphetamine, it can be tedious. And you just need to weigh the pros and cons, whether it's worth doing in your laboratory and for your patients. But yes, it can be done.
All right. Question here from an anesthesiologist. She says that she learned fentanyl has an extensive first pass metabolism. And in relation to that, why is there such an issue with oral fentanyl? Is it just a dose issue that overcomes that first pass metabolism?
Transcutaneous fentanyl. I know there's fentanyl patches are good, but you use them a lot of times, later in the course of a disease, hospice patients, and if you put a fentanyl patch on top of them versus under them, if they're leaning on it, if it's warm, has a lot of blood flow, it's always been a concern for me. Yes, there's a lot of these drugs that do have extensive first pass metabolism. The benzodiazepines, are metabolized so quickly that we don't even see the parent drug in a lot of cases. Oral fentanyl tends to, at least in my experience, not be, at least in my patient populations, tends to not be the major concern. I think that generally we're seeing it, usually we're seeing it injected. You do get the immediate response that way. You don't lose anything in the gut. But it's better from the user's point of view, because when you inject a drug, you get a higher dose directly into you. You don't need to worry as much about what gets lost during absorption.
All right. And then I think one more from Richard here to wrap things up. So if there's a test done for xylazine and it comes back positive, what would the appropriate response be with that result? Would you send them to an addictionologist or discontinue opioid pain meds?
That's a very good question. So, if xylazine comes back positive, it doesn't do our patients as much good to kick them out of a program. If they've been using opioids legally for a long time, and you suddenly remove that, then you're forcing them into the illicit market. The whole point, in my mind, of laboratory testing is to identify a patient or a case where you can intervene, where you find someone who is having problems, where they've fallen off the wagon, so to speak, and you can help bring them back. It's not failing a test. It is proof of a place where we can intervene and hopefully help the patient. So in my mind, if you're not set to or prepared to deal with a patient that's showing signs of illicit drug use, then yes, sending them to a counselor, therapy program, something that can hopefully guide them back on track without hopefully taking the opiate that they have usually become dependent on away from them, because that can have some obviously very negative splashback effects.
All right. Well, Richard just said thank you for answering the questions, and I will second that. Great talk tonight, Dr. Korte. We appreciate your time here on this Wednesday evening. And again, if anybody is wondering about claiming your education credits, there will be an email after the series with the availability to do so. A recording of this webinar is going to be sent out to everyone tomorrow under the address that you registered with. And it will also be available on a couple different places, including our YouTube channel as well. So, Robin, any final words from you?
No, except thank you. It was fantastic. Really appreciate the presentation.
Well, thank you for having me. I appreciate that.
All right. Thanks again, everyone. And if you have any questions or don't get a chance to grab the slides from the handout section, feel free to email us there and we'll get you taken care of. Thanks again. And we look forward to seeing everybody on November 15th for our next talk.
That's what I was going to say. Excellent. We'll see you then.
All right.
Have a good evening, everyone. Bye-bye.